Let me begin by thanking the panel, but I also want to be a little bit provocative for a moment. Clearly we've heard lots of different opinions and positions, and if you go back and read the 1997 report that Chris put together, many of the things we're talking about today were captured in that report. So how can we be assured that 10, 15 years from now, we're not going to be back, or some of us back here, reiterating the same things we've already talked about? So I'd like the panel to be more specific and tell us precisely what they're going to do over the course of the next year or two to realize some of the things that we've talked about. So Chris, for example, when will we have quality metrics? How is that actually going to happen and be implemented? How are we going to really change the role of nurses in a proactive and meaningful way? How are we going to assure in the next year or two that patients are going to have, individuals are going to have access to palliative and hospice care? How are we going to deal with the important issues of our veterans, not just say that it's going to happen, but actually realize it? How are we going to reduce the utilization in intensive care units? Specifically, what are hospitals going to do to be proactive in that? How are we going to make sure that our physicians are in fact doing what they all think that they're doing, but in point of fact not? And how are we going to make sure that education really is exercised? What are the metrics you're going to use in 2016 and let's say in 2018 to actually determine that something has happened? Chris, what are you going to use?
Well, thanks, Phil. I have a personal commitment to actually bring NQF into a more proactive role in helping to solve this problem. We have traditionally been the standard setting role, and people would bring the measure in and our expert committees would evaluate them and say yes or no or maybe, and then it would go forward. But that's not enough. So we are actually now embarking on much more upstream engagement with the Physician Consortium for Practice Improvement that Bob mentioned, with other measure developers, with CMS, and increasingly with Medicaid and the private payers, as I mentioned. So here's why I think we'll make more progress. First of all, one of the things that came out of that 1997 report was a recommendation that there be, and I still remember the words, if not a new specialty, at least a recognized area of expertise in palliative care. And that has happened. So I want to applaud all of those, and probably a lot of them here, who helped to actually make that a reality, Don, and you're among them, of course. But it's not just enough to have standards for specialists in nursing or medicine or pharmacy or any other areas. There really has to be an accountability framework. So what gives me optimism that this is going to happen is because of the urgency of the payment changes that we're seeing and the kind of chaos in the market right now. Secretary Burwell's announcement is a dramatic acceleration in 1 year of a move to alternative payment models, and she has the private payers at the table with her. Oh. So that was a big part, and there's a big event next week at the White House to kick off this engagement network that they're involved in. The only way that's going to work and not backfire is if there's reasonable assurance that this is good quality of care and that we're cutting the waste and not what matters to patients. So there's a kind of a burning platform, I guess.
So
if
we have a shift in measures and incentives that are based on quality, you'll be able to accomplish that?
I think that'll help a lot. But we also need new thinking about how to get the measures. And the thing that gives me hope there is that, 10 years ago even, we didn't have this. Now we do, which is social networking and the ability through the internet and through the cloud to get all kinds of information from patients and their families. Our current measurement structure doesn't really use that nearly adequately enough, but NQF, in partnership with others, is actually going to some of these innovators and developing quicker ways that we can get better feedback from families and patients, and then test beds to really see, are these measures accurately portraying what we think they are. So we don't have to wait 3 years for some article to come out in a journal, as important as that is, but we can actually do real-time testing.
So are you making a pledge we're going to have those metrics in another year?
If I get some help from some of the people in this community, I hope to.
Can I make a comment?
Building on the Department of Veterans Affairs, and I realize I come from my non-fee-for-service world, but we have an NQF-endorsed measure, Bereaved Family Survey. Right. So of the 20,000 veterans that die in our facilities, we started out 8 years ago surveying all of them, and then it evolved into, and that was by phone, then it became a mail-out survey. Now it's a web version of it, and 86% of families rate the last month of care as excellent or very good. And what we do is we take that information, turn around, and we give it to the providers and the teams and say, by the way, we want you to get this feedback, not only the numbers, but the comments. There's open-ended questions. Right. So I just want to put in a plug, if I can, that there are quality measures. It concerns me that accountability becomes the reason for the measure as opposed to actionable change in practice. And I just would like to keep them both on the table.
And we need to be able to do both with the same measures to reduce the burden of unnecessary data collection.
Yeah. Chris doesn't need my protection, but I serve on her board and her executive committee. And, you know, the world of measures is not a straight line. There's a reason, there must be a reason that the practitioners of the world, the researchers of the world, the measure developers of the world have not coalesced around the need to develop a broadly based and broadly accepted and supported set of measures in this area. And
there are a few, mind you, like yours, but not.
But there's no business model for NQF, who's not a measure developer anyway, to go out and try to develop these measures. On the other hand, if we sit around wondering why we have this gap, it's not going to happen. So NQF is starting an effort to try to be able to incubate measures and develop, put funding and effort together in the field and try to speed these things up. So you'll see a lot more of that type of push in these important areas.
So, I mean, I think we recognize, you know, the challenges that are surrounding delivery of care models. But we've talked this morning, and everyone on this panel in some way has alluded to the incredible impact of having or not having conversations with patients that really assess and determine their individual preferences. That's not something that requires more legislation. It just requires a change in action. So how are we going to do that? And can we do it without there being real incentives behind this? What do you think, Steve?
Well, I agree, and I think that the issue is broader than just end-of-life care. We have not viewed the patient's values, goals, and preferences as an integral part of every visit that we provide, certainly as physicians. And I will say, I think that the nursing community has done a much better job of this than the physician community. I think it's more built into their fabric, and I think we need to incorporate that into physicians' care as well. And I think we really need to, we actually need to start at the earliest level of training so that it is part of the fabric. One of the things that I've been personally feeling is that I think people are familiar with what's called a SOAP note. The progress note in a patient's chart, which is subjective, objective, assessment, and plan. And I think there needs to be a second P in there, which is the patient's perspective, essentially. And that every note that we write should have the patient's perspective. And we should be starting that at the level of medical school. And I'd love to see that incorporated into the culture.
On the level of broad system change, in the last 10 years where we've seen really some terrific acceleration around performance improvement in specific areas, I think there's a bit of a sequence that we can now start to see that has supported that. And it is an agreement on definitions or measures or whatever you want to call them, however we want to focus and talk the same language. It's then aided by transparent reporting of how well we do against it. Little sunshine helps a lot. Consumer engagement, which frankly, as I grew up, you kind of turned yourself over to the health system. Well, that's not the case anymore. And consumers have a variety of ways to be empowered and are taking that. But there's also been changed incentives. And there's been changed incentives for providers, but now with high deductible health plans and other financial incentives, you'll see changed incentives for consumers as well. So I think there's a bit of a virtuous cycle here that is going to continue to grow and spread into other areas that will help as well.
Yes.
I'd just say that all this discussion reminds me that we had a breakfast this morning when a bunch of us spoke privately, and I think we do have to be mindful when we talk about the dollars and cents of health care, and particularly in the area of end-of-life care, that we just be aware of this concern that some people view people's financial discussion about end-of-life care about simply saving money.
Yeah.
And that maybe people sort of say, well, if people died a little faster and a little cheaper, it would be better for the system. That's not what we're talking about here. We're talking about quality of life of the people at the end of their life. And so then it also leads me to a broader thought about my frustration as a physician is we always talk about payment reform in healthcare, and we don't talk enough about delivery reform.
Yeah.
And we use the payment as a hammer or whatever you want to call it, a stick, to drive delivery reform. And I, as a physician, would much rather see us talk a little bit more about what's the ideal way to deliver care to our patients to get the best outcome in the most cost-efficient and cost-effective way, and then craft a payment system that facilitates that better delivery system. I think end-of-life care is a great example of where that could be employed, and let's not run to the payment hammer and just think about how we can drive changes in the system through the payment side.
Yeah, no, we're going to go to, we're going to open the floor momentarily, but let me just make a couple of very quick comments and observations. First and foremost, I agree, Robert, with you that the issue of cost should not dominate our discussion. In fact, when our panel began its work leading to this report, we were very clear. We had a lot of debate about this at the beginning, but we were very clear that we were going to focus on quality of life and quality of death. And I think if you look at the recommendations, they really both ensure that, and by accomplishing them will as well control costs. That was one of the issues that was on our agenda, but we do it through quality, not through arbitrariness. The second is that we do have a disconnect. We've talked about the role of professionals, and I agree that, and in our report, we tried to be very broad in making sure that we didn't focus on doctors, that we focused on nurses and social workers and the entire spectrum of individuals who are in the midst of care. But there is a profound disconnect between the way doctors seek their own end of life and what actually happens to the patients that they care for. And this has been demonstrated in a number of different studies over the years, and it's quite clear that, if you ask physicians and look at the data, about 80% of them are very clear that they want to die at home and do so with pain medication and the like. What happens to patients that they care for is quite different, and yet those same patients have that same percentage of wanting to also die at home. So the cultural change that needs to happen in this country begins with education, but it has to be very actualized in how we, as a medical community, broadly defined, and our use of the word medicine, Pam, in the report was not as a profession, but as a specific discipline, broadly defined, everyone included. We all have to go through this cultural change to be really moving the agenda forward.